you, sir. So we will move on to the next two talks on cardiac MR. First, Dr. Richa. She is consultant cardiothoracic radiologist from the Narayana Vidyalaya, same place. So she is going to talk on the strain imaging using cardiac MR. Over to you, Dr. Richa.
Hello. Thank you, sir, for the kind introduction. So I'll try and quickly finish it. So strain imaging on cardiac MR. So I'm going to talk about strain on cardiac MR, and I'll avoid repetitions of what Dr. Shan has already talked about. So I'm going to talk about what is strain in a line, and then what are its uses, how does it compare with echo, and there are multiple MR softwares which do strain. So how do they compare with each other, and how does cardiac MR strain appear in different diseases? So I find physics definitions very difficult to understand or difficult to remember. So strain is simply a change in measurement of the myocardial tissue between relaxed and contracted states. So every cardiac cycle, when the heart myocardial muscles deform, where it shortens, lengthens, thickens, and rotates during the cardiac cycle, measurement of those indicators constitutes strain. So the myocardial fibers are complex. So we have endocardial, subendocardial fibers with left-sided helix, epicardial fibers with a right-sided helix, circumferential mid-wall fibers. So when they contract, so if the contraction is from base to apex, it's longitudinal strain. When it's radial thickening of the muscles, it's a radial strain, and circumferential strain is along the circumference of the fibers. So by convention, when the myocardial fibers lengthen, thicken, or there's a clockwise rotation, we give it positive values, and if shortens, thins, and counterclockwise rotation, then we give it negative values. So our longitudinal and circumferential strains will always have negative values, and radial strains will have positive values. So how do we do strain on cardiac MR? We saw an excellent lecture on how they do it by echo. So how we do it by MR, there are multiple techniques which MR can use to do strain. These are some of the few what I've written: tagging, strain encoded imaging, displacement encoding with stimulated echoes, tissue phase mapping. All these sequences can be used to do strain imaging on MR. Feature mapping is another technique which is most recent and quite commonly used for strain, because it does not involve the acquisition of additional sequence. The sequence which we routinely use for cardiac MR, 2-chamber, 4-chamber, 3 chambers, and short axis, just require processing to give us the strain values. So this is quite commonly used. So where do we use strain? What's its use? We already have functional assessment, we have LGE, we have T1 mapping, parametric mappings. So what's the role of strain? How does it help? So the use of strain is it helps in identifying LV dysfunction even before the LV ejection fraction falls. So this is especially used in anti-cancer therapy cardiotoxicity. So how do we use this? So when patient undergoes cancer treatment, patient undergoing cancer treatment, LV systolic dysfunction is diagnosed in these patients if LVEF drops 10% below 50, or if we have a baseline MR, it drops 15% from the baseline. Another use of strain is in various cardiomyopathies, where it's an early indicator. Even if there are no LV dysfunction or LG abnormalities, the strain may be abnormal. Another use is in LV dyssynchrony, to determine which patients will benefit from cardiac resynchronization. So how does it do it? So there's an indicator called time to peak strain. Means it is, as the name says, time from beginning of cardiac cycle to the time of maximum strain. So if the difference is between more than 130 milliseconds, it contributes to, it's called mechanical LV dyssynchrony. One another indication is in heart failure with preserved EF patients. So strain is one of the parameters which can help in assessment of these patients in cardiac MR in addition to all this paraphernalia that we have. In such patients, we can use LA volume, the mappings, the LGE to determine the cause of heart failure with preserved ejection fraction. So as we see in this graph, in patients with HFpEF or diastolic dysfunction, in stage A cardiac failure, the strain is the first parameter to become abnormal. And then LV hypertrophy fibrosis and all happens much later. So if we detect the abnormality here itself, it's an early detection and helps with a better prognosis of the patient. This was a study where they compared a cardiac MR GLS, the global longitudinal strain, with invasive diastolic functional indices, and they found that CMR LV GLS independently predicts and strongly correlates with invasive LV relaxation. So now we come to how does cardiac MR strain compare to echo strain. So there have been multiple studies. This is one such study published in JCMR where they compared echo with CMR strain, and they also took into consideration LGE, and they concluded that there is good intertechnique agreement between echo and MR strains. They are highly reproducible. And in fact, circumferential strains better reflects the presence of LG than longitudinal strain. This is another study which compared MR feature tracking strain with echo speckle tracking strain, and they said on similar lines, though not interchangeable, they have good correlation, and so it's especially useful if patients have suboptimal echo quality. However, the story doesn't stop there. There are multiple other studies. This study just specifically compares echo and MR in patients with MI. And it said it has good agreement between echo and MR. This is strain and MR in cancer patients. However, the study concluded that there is weak correlation between echo and MR strain. This is another study which compared again in cancer patients echo and MR strain, and they just concluded that both illustrate cancer-related cardiomyopathy. Further, we are doing an ongoing study, prospective study at our hospital, where we are evaluating patients with different pathologies, ischemic heart disease, DCM and HCM, on echo and CMR at the same sitting. We do the strains. We have excluded valvular heart disease, RV cardiomyopathy, congenital heart disease, and pericardial effusion patients, and both are being evaluated on CAS software. So up till now, we've done 31 patients with an age range of 29 to 74, and 74% were male, and this is the case distribution, where you can see right now we have more of ischemic heart disease patients. Just to show how our software does the strain. This is a DCM patient, this is an HCM patient, and this is an ischemic heart disease patient. So our findings were that all patients in our study had deranged GLS on echo. None of them had normal strain. However, MR showed 6 patients who had normal GLS, and all those 6 were ischemic heart disease cases. This is just again of those DCM, HCM, and ischemic heart disease patients. So we did the Pearson correlation coefficient, and the R value was found to be positive. To summarize, our study, there's positive correlation coefficient between echo and CMR GLS. The echo GLS values were more abnormal compared to MRI, and echo showed all all patients had abnormal GLS, but MR at least 6 patients had normal GLS. This is another study where we included only muscular dystrophy patients. So this is important because a lot of these patients have just subclinical cardiac involvement. Even if we do cardiac MR, the ejection fraction and LGE may be normal. So we have done a study on 34 patients over a period of 5-6 years, and we have the age range was 7 to 28. Of 34 cases, 28 were Duchenne muscular dystrophy and 6 were Becker's. And this is just a video of the feature tracking. So the average LVEF was around 56% on MR and 59 on echo, and we had deranged GLS in all cases on echo as well as MR. So as you can see, all the cases are abnormal, with the mean being minus 30.5 on CMR, more abnormal on CMR than on echo. So to conclude all these studies, the correlation between strain values in CMR and echo is variable. So to bring it all together, there's modest to good agreement between CMR and echo when it comes to global strain. However, it's poorer when we do segmental strain. So let's talk about how CMR strain compares on different softwares. This is a study in JCMR which compared 3 softwares in patients with HFpEF, and they said that all software packages were able to detect abnormal strain in HFpEF patients compared to normal controls. This is our study where we scanned 50 age and gender matched normal volunteers. Normal patients, if there was abnormal EF or T1 value, we excluded them. We evaluated them on 2 softwares, and we did inter and intra-observer variability also. So this is our results. Our average on vendor 1, the GLS was minus 17.3, and on the other vendor was minus 18.6. And so GLS was less than minus 18 in more than half of the patients, about 33 patients. And there was significant difference between GLS and GRS between the 2 softwares. As you can see here, there's statistically significant difference. However, there was good intra and inter-observer concurrence, and age and gender did not have an influence on the performance in our study. So we can see that wide variability exists even in the normal reference ranges from strain, because it is dependent on multiple factors. It depends on the imaging technique, where the spatial and temporal resolutions used come into play, the analysis software, which may use different boundary definitions, different algorithms, different region size, the operator, how the operator traces the contours, the patient demographics of age, race, sex, race, or even their hemodynamic conditions at the time of performing the strain, like the heart rate, blood pressure, and loading conditions at that time will all affect the strain values. Just a quick word on RV strain. It's challenging because of the complex shape, thin wall, trabeculations, retrosternal location. So you can imagine how labor intensive the feature tracking of the thin RV wall would be on the cine sequences. So however, it's reduced in ARVD, pulmonary hypertension, and congenital heart diseases. ILA strain sir has just spoken about. So it's a main modulator in LV filling, and it has good utility and prognostic assessment in HCM, HFpEF, and ischemic heart disease.
Richa, can you sum up?
Last slide. So to conclude, MR strain is one of the first parameters to be affected, even without LV dysfunction or LG abnormalities. The problem is that there is large number of competing methodologies. None of them are optimal, and they are not fully standardized. Eco strain is not interchangeable with CMR, but both of them show positive correlation. And the strain values not only differ with modality, but also with different softwares. It's still early days. We need more research and more standardization to reach a proper conclusion. Thank you.
Thank you, Dr. Richa. It's a wonderful collection of cases and the review of literature. I request Dr. Tarun Mittal to facilitate Dr. Richa.